Hello and welcome. Today, we're diving deep into a complex but crucial topic, tacrolimus nephrotoxicity, a serious complication that can affect the kidneys of patients taking tacrolimus, a powerful immunosuppressant medication. We'll explore its causes, how it damages the kidneys, how doctors diagnose it, and what can be done to manage and prevent it. So what causes tacrolimus nephrotoxicity? Simply put, it's a consequence of the drug tacrolimus itself. Tacrolimus is primarily used to prevent organ rejection after transplantation. It works by suppressing the immune system, specifically T cells, which are responsible for attacking foreign substances, including a transplanted organ. However, this same immunosuppressive action can also harm the kidneys. The drug's direct toxic effects on the renal tubules and blood vessels are the main culprits. Things like higher tacrolimus blood levels and prolonged exposure increase the risk. Now let's get a bit technical and discuss the pathophysiology. Tacrolimus nephrotoxicity is a multifaceted process. Firstly, tacrolimus causes vasoconstriction, meaning it narrows the blood vessels supplying the kidneys. This reduces blood flow and oxygen delivery, leading to ischemia, or oxygen deprivation, in the kidney tissues. Secondly, tacrolimus directly damages the cells lining the renal tubules, the functional units of the kidneys responsible for filtering waste. This tubular injury disrupts their ability to reabsorb essential substances and excrete waste products. Chronic exposure can lead to interstitial fibrosis, a scarring process within the kidney tissue, which further impairs kidney function. In severe cases, glomerulosclerosis, or scarring of the kidney's filtering units, can also occur, leading to chronic kidney disease. Regarding epidemiology, it's challenging to pinpoint exact numbers, but tacrolimus nephrotoxicity is a significant concern, especially in organ transplant recipients. The incidence varies depending on factors like the type of transplant, the dosage of tacrolimus, and individual patient characteristics. Patients on higher doses, those with pre-existing kidney problems, and those who are taking other nephrotoxic medications are at a higher risk. Chronic tacrolimus exposure over months or years is almost certain to have an impact on kidney function to some extent. Identifying tacrolimus nephrotoxicity early is key. The signs and symptoms can be subtle at first. One of the earliest indicators is often a gradual rise in serum creatinine, a blood marker of kidney function. Patients may also experience a decrease in urine output, edema, swelling, and high blood pressure. Proteinuria, the presence of protein in the urine, can also be a sign. In more advanced stages, symptoms of kidney failure, such as fatigue, nausea, loss of appetite, and shortness of breath, may develop. Diagnosing tacrolimus nephrotoxicity requires a comprehensive approach. First, a thorough medical history, including medications and any pre-existing kidney conditions, is essential. Blood tests to assess kidney function, such as serum creatinine and blood urea nitrogen sibune, are crucial. Urine tests, including urinalysis and urine protein measurements, are also important. In some cases, a kidney biopsy, where a small sample of kidney tissue is examined under a microscope, may be necessary to confirm the diagnosis and assess the extent of kidney damage. Ruling out other potential causes of kidney dysfunction, such as infection or rejection, is also crucial. While there aren't distinct types of tacrolimus nephrotoxicity in the traditional sense, it can be categorized based on severity and chronicity. Acute tacrolimus nephrotoxicity typically occurs soon after starting the medication or after a significant increase in dosage. Chronic tacrolimus nephrotoxicity develops over time, usually months or years, due to long-term exposure to the drug. Management of tacrolimus nephrotoxicity focuses on minimizing further kidney damage and preserving remaining kidney function. The primary approach is dose reduction or, if possible, discontinuation of tacrolimus. Switching to an alternative immunosuppressant may also be considered. Other management strategies include controlling blood pressure with medications like ACE inhibitors or ARBs, managing edema with diuretics, and dietary modifications to reduce protein and sodium intake. In severe cases of kidney failure, dialysis or kidney transplantation may be necessary. Prevention is the best approach. Careful monitoring of tacrolimus blood levels is essential to ensure they stay within the therapeutic range, avoiding excessively high levels that can damage the kidneys. Regular monitoring of kidney function through blood and urine tests is also crucial. Avoiding other nephrotoxic medications, such as ANs, and ensuring adequate hydration can further reduce the risk. Close collaboration between the transplant team and the patient is vital for early detection and intervention. The prognosis of tacrolimus nephrotoxicity depends on the severity of the kidney damage and the effectiveness of treatment. Early detection and intervention can often prevent progression to end-stage renal disease. However, chronic tacrolimus nephrotoxicity can lead to irreversible kidney damage and the need for long-term dialysis or kidney transplantation. Recent research is focused on developing more selective immunosuppressants with fewer nephrotoxic effects. Studies are also investigating novel therapies to protect the kidneys from tacrolimus-induced damage. One potential avenue involves exploring agents that can counteract the vasoconstrictive effects of tacrolimus or protect tubular cells from its direct toxicity. As research continues, we hope to see improved strategies for preventing and managing this challenging complication.